everyone. It's the Infection Control Matters Christmas special, and Brett Mitchell here. G'day, Phil.
G'day, Brett. Martin.
And Martin, of course.
Hey, hello, guys. All right.
Great to have the three of us for this Christmas special. I'm sure people have heard our Christmas specials before. They're just a bit of a mix of whatever we feel like doing on the day, really.
And those people have just turned off.
Yeah, as is traditional, you guys are recording this in the evening where you have either a glass of wine or a beer, and I have tea because it's 8 a.m. Yeah.
Yeah, one year we should
we should
fly you to Australia, Martin.
That would be better, yeah.
Oh, right. Well, what have we got lined up on this podcast? A few things. We thought we would run through some things that we enjoyed about the year from various things. So where are we going to kick off with this? Should we start with a favourite podcast of the year?
Well, I'm going to combine it with my favourite moment, if you like, almost.
Okay. Go on, Mum.
I mean, I enjoyed doing the podcast at the IPS, the Infection Control Matters Live, because I can just chuck questions at people on stage and, make it not awkward, but just say what I think, really, because I'm not employed by anybody. So that's really quite refreshing. And one of my favourite moments from that was, if your budget was being cut, what would you give up doing? And a couple of them immediately said hand hygiene auditing, which is interesting. I think
surprising.
I agree. But actually, I think my favourite moment, I actually enjoyed that much during the year, and don't travel as much as I used to. So, actually chatting to a couple of practitioners about their posters at IPS. So you can go to the conference and hear the great and the good, and they'll give you a really nice scientific lecture. But actually chatting to a couple of practitioners who've done a piece of local work. Okay, so there was Fran from Gloucester about, the work where she's trying to get people at local level to assess their own infection control risks. She was quite passionate about that. And Catherine from Plymouth, who's a dental nurse, just talking about implementing a mouth care program. It really means something to those folks. They've got a project. They're passionate about it. They've seen it through. They've got great results. And talking to the people about at the front line about their successes, I really enjoyed doing that, because we can all go and sit and listen to the Didiers of this world give fantastic presentations. And yes, they are passionate about their subject, but I really quite enjoyed hearing about local action, bringing local good effects for people in their own hospital. So I think actually that was, in retrospect, one of my favourite moments of the year.
Favourite podcast and moment?
Yeah, I think so. Well, maybe not my favourite podcast, but I think the live one was quite good as well. But yeah,
and the live one's got a lot of. I think it's one of the most popular podcasts.
Well, the 2024 one is on. Yeah, that's the number one podcast that we've ever recorded.
The one we did in was that Manchester?
Was it Manchester? Yeah, I think so. I don't know.
Look, the live podcasts work well. I enjoy. Well, I only done one, but I enjoy doing them, and they're also good to listen to, I reckon. So, well, I'll go with my favourite podcast next, and I really enjoyed this podcast because the company was okay, but it was in New Zealand at a little establishment, and Martin and I had a fascinating chat about 3 or 4 papers to do with toilets and plumes and risks associated with how long you should leave it before someone's done a number 2 and you go into the room to reduce your risk. So I actually enjoyed that discussion because I just thought it was a fun discussion about a topic that was a bit of fun. And there was also some practical components in there, a fair bit of science thrown in the mix. But I really enjoyed that one because of probably seeing the company and the topic, and the fact we combined, I think, 3 or 4 papers in that podcast in one. So that was probably my favourite.
Yeah, that was fun.
I think that's got a lot of views too.
Yeah, funnily enough, I gave a talk at the FIS meeting a couple of weeks ago where I had to do my top 10-ish papers of the year, but I chucked in an extra one, which was about lid closure whilst flushing.
Yeah.
And everything, if you are going to put the lid down, the height of the lid is critical. So you've got to get down to 2 millimeters if it's going to have any effect. If it's above 2 millimeters, you can see everybody going around with a tape measure. Oh, hang on, this is a 6 mil gap. It's not going to be.
It only matters if you've got a seat lid, I guess. Most of the public toilets don't even have a toilet seat to sit on. So
no, that's also true. But it was making the point that actually having well ventilated toilets, and possibly when the door shuts, if you had a ventilation system that refreshed the air very quickly, might make a bit of an impact, which I thought was good, because generally the only thing you've got to as an indication of whether it's okay to go in is your nose.
Yeah,
and if you're desperate,
and how many times have we been to a party, a wedding, a infection control conference dinner, and people have got sick, or a conference, and it just shows how important perhaps some of these ventilation issues are, plus perhaps some of the other issues, not just the food.
Absolutely.
Hygiene.
Yeah, we need toilets. We need airplane toilets. So they just that vacuum for
that's a huge suck out of those, isn't it?
Yeah. Bit of negative ventilation in the toilets. There you go.
So, Phil, what's been your favourite podcast or presentation or favourite memorable thing from the year?
Favourite's probably not the exact word you'd use, but one that stuck in my mind, Brett, was with you, and we were at ICPIC and we had a chat with David Webber.
Oh, yes.
And it was following the talk that he presented at the conference in his role as president of SHE, talking about, I think it was 25 minutes that he spoke for, non-stop, about the effects of some of the cuts that are occurring in the States, and how that potentially could affect all the work that is being done across the USA, and then of course the rippling effect that it has internationally as well. And so it was a really sobering conversation, sobering podcast. It was a sobering presentation. I think the room at the end of the presentation was silent, and it was a good to chat to David and get further thoughts on that.
That's a cracker of a one, Phil.
Yeah, that is.
Not just because it's Christmas time, but that's a poor joke, isn't it? That
I didn't even notice it.
You nailed it on the head. It was a favourite podcast, but for a different reason. It was a really somber. I was with you for that ECPIC conference. I never heard the crowds so quiet and everyone thinking, "Oh my God." And so I think that was a really good. And what was refreshing, I don't know if we explored. I can't remember if we explored this in the podcast or not, but a lot of the US speakers who went to ICPIC, it felt like they were muzzled. They weren't allowed to say what they could say, although they really wanted to say. They'd get up and they would say they're there in their own time. They'd taken their own leave, and that no one was funding them. The organisation, the hospital wasn't funding them. They weren't presenting any data from the CDC, and they refrained from answering questions that might put them in any political hot water. And it was such a shame to see these elite clinicians and researchers and academics almost like they were muzzled because they were worried about what the implications were when they got back to the US. And it was real. It was. I'm not making that up. So it was a real shame. And I think so. David's talk, because he could actually speak freely, was a very powerful one, I think. So
yes, indeed.
Well, that's sombering, isn't it?
Well, it is sombering. Well, you probably just ruined your chances of getting a US visa in the near future as well.
Yeah, I got no. But that, actually, I saw on the news, you're Australian, you're having to give up 5 years of your social media data now to get a visitor visa to the US. Yeah. So you're probably right there.
Yeah. Interestingly, just on that little point, the fact that they're not producing very much, I thought one thing we might do for this podcast was actually look at any new guidelines that have come out this year and seen what implications for practice there may be. And in any of the major journals, I could find not one new guideline. And I know SHE haven't put out any, and CDC won't be putting out any. And I'm wondering what's going on. And so I actually had a quick look at 2024, and there wasn't a lot in 2024 either. So either we're not producing new guidelines or we're not producing good enough evidence. So anyway, that's just
well, it could be a combination of those things.
Yeah, it could be.
I want to also just talk about another favourite moment of mine, and to do this, I'm going to attempt to share my screen, share the audio. So I hope this works, because this could be one of those moments that I'm going to turn it up. Hang on, let me just turn it up first before I share this, and Martin can do his magic to. All right, hopefully you can hear this. Phil, nod if you can hear this. G'day everybody, it's Brett Mitchell here, and I'm actually taking a role as a spy. I'm at the Washington hotel in Mayfield in London, and there's a certain Mr. Kiernan staying at the same hotel. He doesn't know that I'm in the country, and he had a recent birthday that needed celebrating. So shortly, we'll be surprising Martin, so stay tuned. Right, I'm on the hunt for Martin Kiernan. Apparently he's held up in a bar not too far from here. I would have been there a few minutes ago, except I went the wrong way. And for those who know me, that's not uncommon. All right, next update coming. Okay, I'm at the bar. I'm about to go inside, see if we can find him.
Hello,
Hi
sir.
there, how are you?
Looking for drinks?
Yes, I have. Got a booking.
Just a moment.
Thank you. Oh, yes. I can see them. There we go, thank you. All right, here we go, I can see them. Hello, Brett Mitchell, Pet Control Matters. How are you?
Do you know what?
This is your night.
There we go. That was my favourite moment, I think, of 2025 was surprising Martin a few weeks ago in a bar in London.
It's fair to say when you're out for a meal in London, you're not expecting somebody from Sydney to turn up. I don't think that's much appreciated.
And there was plenty of drama before that, but trying to get there on time. So anyway, yes, that was a lovely evening, and always good to spend time with Phil and Martin. So anyway, all right, and I'm glad that little recording worked, I think, on the audio. What else are we going to talk about? We're going to talk about an RCT that you would most like to see.
Yeah. So in the absence of guidelines we could talk about, I thought, well, let's have a look at the major journals like Journal of Hospital Infection, Infectious Disease and Health, ICHE, ARIC, American Journal of Infection Control, and just pull out any new systematic reviews of the year. And I came up with a list of 59 systematic reviews from those journals so far in 2025. So I sent the list out to you two, and I thought, let's just pick one each and have a little chat about it. So now we don't know which one we picked. We could all have picked the same one, but let's have a little chat about systematic reviews. So who wants to go first? Phil, do you want to go first? I'll go last.
Thanks, Martin. I'll go first. Systematic review, and I'll talk about my most enjoyable moment later on.
Yes.
Because it's on a happier note. My systematic review is a quick scan of that list, Martin, and I found
it's a systematic scan of the systematic
scan of the list, and I found a title that caught my eye. And that's something that's close to my heart, and that's a systematic review and meta-analysis of outcomes associated with incisional and organ space surgical site infections in abdominal surgery patients, and it was authored by Shalini Elangovan, apologies for the name there, and published in Antimicrobial Resistance Infection Control just a couple of months ago, and the senior author was Nick Graves. It was a systematic review, obviously. I'll cut to the chase. I won't go for too long, but they combined deep and superficial infections into an incisional infection category and compared those with the organ space surgical site infections, and looked at the excess length of stay, the mortality risk, readmission rates, and repeat surgery rates. They identified 20 studies in the end. There was a reasonable to high amount of heterogeneity amongst the studies, which caused a few limitations, and a quarter of the studies didn't provide any definitions of surgical site infection. But the meta-analysis indicated that the excess length of stay for the incisional surgical site infection was 5 days, and for an organ space surgical site infection was 14 days. So quite a decent difference there. The mortality risk was 1.62 for incisional and 2.75 for organ space. The readmission rates, incisional was 16% and organ space was at more than double that, and repeat surgery was for incisional 4% and organ space was again more than double that. So the organ space in surgical site infections in abdominal surgery clearly are causing a lot of burden. And we should perhaps be thinking about targeting some particular specific interventions to those organ-space infections in surgical site infections. So that was my little summary.
So, Phil, here's a hypothetical for you. If you could only do one type of surveillance for surgical site infection, C-section, hips, knees, so C-section or hips, knees, or abdominal surgery. Let's just do those three. What would you choose?
Which procedure would I do?
Yeah, which procedure would you do?
Surveillance on?
Yeah.
Probably. Well, I think it depends on the purpose of your surveillance, Brett, doesn't it?
I knew I was going to get an answer like that.
To have the biggest impact quickly, you'd look at the dirty surgery, the colorectal abdominal surgery. But then again, it's very difficult to divert your attention away from mothers and babies at the same time. So, and hips and knees cause nasty deep infection. So it would. I think you would have to look at things as they were on the day and decide.
Yeah, fair enough. I just wondered whether that reading that changed your view about impact and whether that up the ante for abdominal surgical site infection surveillance.
Yeah, I think there's lots to be done in dirty surgery, and particularly with the bundles that we know that work that don't always get applied.
It's interesting, isn't it? Because people tend to, I think, go, it's dirty surgery, there's going to be some infection. And that isn't necessarily the case that you have to have infection. There are plenty of interventions out there. And I know Judith Tanner's done some work and presented on a previous podcast about how poor warming is and what goes wrong to stop people getting warmed and how actually difficult it is to get something that has quite good evidence actually implemented. That is a good one on surgical site infection because it looks at outcomes and therefore possibly increases people's interest in doing something about it. What I did see on the list was there's quite a few risk factors for infection in surgery.
Yes, there was a couple
on various different procedures, and it almost like you're down your list of the operating list and go, oh, hang on, there's one there. Nobody's done a systematic review on risk factors for that. And what you get is age, you get BMI, you get smoking. How many of these things are modifiable? Sorry, mate, you're over a certain age, we're not going to do, so if you want to reduce surgical site infection, you don't do anybody over the age of 40, BMI of 19, or whatever, and nobody's ever smoked, and our surgical site infection rate is going to drop dramatically. And these things don't often pick out modifiable risk factors in the short term that would make enough of a difference. And I do wonder about the value of those because they all pretty much say the same sort of thing.
So do you reckon a better title for some of these explorations would be modifiable risk factors for X and Y?
And what would be modifiable in a short enough time period for it to actually make an impact? People say, give up smoking, your surgery's next week. Well, that might help the anaesthetist, but I'm not sure, what are the modifiable risk factors? So I'd like to see somebody do a bit of a review on that, I think.
Well, there we go. You put the call out, Martin. Maybe we'll see one next year.
Well, we need
that would
money.
be quite funny if we did, and I hope someone does. I kind of knew, I suspected Phil would go for that one, or one that had surgical site infections in it at least. And I'm sure, seeing as how you're going last, you said, Martin, that Phil will probably have guessed what I'm going to go for. and that is something to do with cleaning. So there was a systematic, actually, I was going to make a comment about the systematic review. But anyway, I'll come back to that. And yes, this review is about ultraviolet light disinfection on reducing hospital-associated infections. Morgeri, and again, apologies for the mispronunciation, was the first author. And it was in the Journal of Hospital Infection this year, published towards the start of the year. So the purpose of this review is to look at ultraviolet light that included UVC and pulse xenon and unspecified UV light. And it was to look at the impact of these on healthcare-associated infections. The review found 25 studies in this area. Their conclusions were that pulse xenon, there were several studies of pulse xenon reported reductions in infections, up to 70% for C. diff. And similarly for UVC, that it was found to reduce HAIs, and its effectiveness varied depending on pathogens and healthcare settings. So then when I looked at the table in this paper, I went and thought to myself, I think I remember reading, and if not talking about a RCT, looking at Pulse Z on this podcast. And if it wasn't on the podcast, it must have been when I did a top papers presentation or something, or a paper presentation throughout the year. And I thought, that's not on the list. So I've included papers in this review. So I went back to look at the search terms, and this review was done until July. The search reviewed literature up until mid 2023. And I think that's a really important point when you're looking at any systematic review, because sometimes that's probably an okay time frame. That's 18 months since the search to publication. But it just shows that this is out of date before it even gets going, right? So this for me is a classic example of why we in infection control, and we're going to talk about wish lists, I think, later, but we need living guidelines. We need living evidence, because here we go. We've got a bunch of studies saying something. And when I looked at table one and thought there's a study missing that I know of, yep, it was published during that time. Why that's important is because I think the author's conclusion. So the authors concluded or made suggestions about Pulse Z on UVC being effective. And when I looked at table one, the studies included were all either quasi-experimental or observational, no RCTs. And then I thought to myself, there is an RCT, and I'm sure I've talked about it. And yes, there is, from DAR. And this was a study published in Clinical Infectious Disease in 2024. And it was a cluster-controlled, double-blinded, interventional crossover design. And their conclusion in that RCT was that, this is called the LAMP study, that UVC disinfection, in this case it was Pulse Xenon, did not demonstrate reductions in healthcare associated infections. So it's another example of quasi and observational studies saying one thing, and an RCT showing the completely, and a really well designed RCT showing the complete opposite. So where does that leave us for this? Probably no idea. In terms of Pulse Xenon, I think you'd need another RCT, and then if it's pointing in the same direction, I'd probably ignore the observational studies. So for me, this is a telltale sign of looking at search dates, the need for living evidence, and our reliance in infection control on observational data and non-experimental designs, and that can potentially come with flaws. The UVC side of things, there was several experimental designs included in that systematic review for UVC showing some benefits. I've probably got more confidence about that than Pulse Xenon, but you could be misled just by not thinking about the detail a bit. So that's why I like this one, Phil.
It's an interesting point, isn't it? The high tech surface cleaning seems to get quite a lot of attention, and people quite like to put them in. I'm interested in the fact that I've never ever seen, and I may be wrong, and I'm very happy to be corrected, any cost effectiveness study done on a high tech cleaning intervention like UVC, which either to me means they've done them and they're not cost effective, so people haven't published them, or they've not done them. You know, because I mean, you showed with clean it's cost effective. Why hasn't somebody done something similar with?
Same with Reach study as well.
Yeah,
cost effective.
Yeah.
So
Brett, you mentioned living guidelines. Do you want to tell us what you mean by that?
Yeah, so living guidelines. In COVID times,
they were so good. Yeah.
They had the COVID or the living guidelines.
No, the living guidelines. I think that was absolutely brilliant.
Yeah,
we did a podcast back in the day.
We did, we did. So we might reference that in the
in the blurb.
Spiel. Yeah. But the short version of it is that it's the ability to basically have a systematic review that is regularly updated, and so as new evidence comes in, it can be put into meta-analysis and can be updated fortnightly, monthly, whatever time frame you would like. But essentially, you know what the current evidence for any particular question is. One of the downsides, of course, you have a very focused question quite often to be able to answer that. But that's what I'm talking about, living guidelines. Now, it's not going to be possible to have living guidelines for everything in infection control, but I think there's probably some key questions in key areas. And in environmental cleaning, I think the disinfection one is one of those. And I think there's probably plenty in surgical site infection that you come up with that would also be very similar, maybe in other areas as well. So yeah, that's what I'd love to see. But yeah,
I think I love the beauty of those because you actually had all professional groups involved. You know, because you often get oh, we say do this, and then the Royal College of Anaesthetists says something different, and the Royal College of Surgeons said something different, and you actually managed to draw people together. But, I mean, I know it was an international crisis or global crisis, and that's why people did come together. But it would be nice to get people together and get some sort of consensus that it would be workable for day-to-day stuff, because, I see antimicrobial resistance as sort of a COVID that's sleeping along at the moment. It doesn't get the attention that it should do because of other major global events, and prevention is going to be often all we've got left within a few years with the reduction in antibiotics that we're going to be available to us. So.
All right, man.
Well, I'm going to go on hand hygiene.
I wouldn't have guessed that.
No. Well, I am. And I'm not anti-hand hygiene or anything like that. Go on.
No, I'm curious.
Okay, so there was a very nice systematic review published in the American Journal of Infection Control called Quality of Hand Hygiene Performance, a Systematic Literature Review. The lead author is Julia Ferreira from Brazil, Sao Paulo, but she's working with a big group, including Mike Edmund, Eli Perencevic, and Mitch Goto from Iowa. So it's a very nice systematic review looking at compliance versus performance quality. And many of us will go out and measure compliance. In other words, did you do anything? And what's the proportion of any hand hygiene action performed? And, you can get rates if you're doing it covertly for like 23%, or you can get 90+%, which is what people tend to report because there's an infection prevention practitioner standing there with a clipboard monitoring you. And there are electronic systems out there, but they don't measure compliance with the WHO 5 moments anyway, so that's an indication. But what we don't really look at is the performance quality. So are we measuring incompetence all the time? And that's why I struggle a little bit with, because we don't look at whether people execute these recommended steps properly. We don't look at have they got enough of the antimicrobial hand rub or the soap. Are they actually covering the hand surface properly? What's the duration like? We don't look at anything like that. It's sort of anything. And I suspect the only time people will ever do the WHO, or actually it was the original ALIF method, 6-step protocol, is the day they're trained to do it and have to do it for an assessment, and they never do it again afterwards. And if you actually examine what people are doing, you get full compliance is very rare. They found it as low as just about 8% in some studies of people actually using what appeared to be the correct technique. Now, I'm not suggesting we go and measure the actual hand coverage, but even if you can modify the technique a little bit, and Sarah Shudin-Sutter produced a couple of very nice papers on a modified 3-step technique, which is much easier to learn and much easier to execute correctly in the real world. They found a few papers have found a comparable microbial reduction to a 6-step method. And I know a Scottish group has looked at it and said, well, it's maybe slightly suboptimal. Well, it might be slightly suboptimal in a perfect world, but we're not actually working in a perfect world. And Sarah Shudin-Sutter's work showed that you could actually improve compliance and execution quality by 50-odd%. So that's my little pick on this one. I think we're measuring whether you do something. We're measuring quantity, not quality. And I think it would be better to actually go around measuring or actually observing to see if people are doing something that might actually work rather than just something. So that's my systematic review of the year. Let's have a change in the way we're monitoring hand hygiene.
I think it's an important point, Martin. It's no good being 100% compliant if you're not doing it the correct way. And I would have thought if there is a lot of auditing, and I would have expected that it is up to the auditors actually to do some education if they do note that people, whilst they're auditing their hand hygiene, aren't doing the correct technique. But of course, they possibly could be too busy to do that, and they're just after the numbers and ticking the box, and they move on. But you would think that would be a good opportunity to educate people, at least in the correct method.
The other couple of things crossed my mind. I wonder whether AI will help with that technique side of things. We're starting to see a lot of the use of AI to be able to pick up individual actions and correct actions, and maybe the application or the technique will eventually be able to get picked up by AI in a non-identifiable way. And I don't think we're too far away from that, to be honest. And we've seen lots of hand hygiene related AI things come on the market in the last 12 months or so. So I wonder whether that might be a way to be able to look at quality in addition to quantity.
If you can automate it, people could go off and start doing things that I think possibly are at least as impactful, which is measuring how well we decontaminate reusable patient equipment. We don't seem to do that, right. And I think that was a key finding of Clean myself. It was the auditing, the feedback, and the retraining. Well, that's exactly what we should be doing for hand hygiene. So, I think actually it. And the other thing is, if you took the Clean, because people are a bit, 35% reduction, do really believe that. Well, if we said we put into place this study, but it was hand hygiene, and we were auditing hand hygiene, and we were looking at technique, and if it wasn't quite right, we were retraining on the spot, everybody would go, that's a fantastic result, because I think they would really want to believe that hand hygiene has that effect. I'm sure it does if you do it correctly. That's another thing we could measure. So there's a study out there for somebody, I think.
All right. Well, we've got a couple of things on the agenda, and we always go on quite long with this podcast for Christmas, but we won't go on long. But what about RCT you'd most like to see next year or the year after? Any thoughts?
Yeah, I've got one. There was a paper from Diane Baker's group that showed an association between oral hygiene and mobility and reduction of HAP. So there are an increasing number of studies that are published and hopefully will be published on the oral hygiene aspect. But I'd actually like to see an RCT with a guaranteed amount of movement put in. A patient will do this amount of movement, or some, a properly designed RCT showing that actually getting people moving has a bit of an effect as well. Because it seems through all the case control studies and the quasi-experimental work that those two things are the most key. So it's growing for oral hygiene. And I think people are accepting that now, even though the message isn't really out there yet. I think getting people moving instead of just pushing them around on a chair all the time, encouraging to move. The problem is that's going to take resource, because often we move people around on a chair because it's quicker, and we haven't got enough people to actually support them, enough physios, enough physio helpers and that sort of stuff. But that actually might be a really nice study to put in place, somebody on the ward who would actually help people move, cost that, and look at the cost effectiveness of that as well, getting back to getting people moving as quickly as possible. So that would be the RCT I'd like to see.
Oh, yeah, I like that one. What about you, Phil? Have you got any?
No, I skipped this one actually, Brady. I don't have an RCT that I'd like. Well, I'll say this and then I'll throw it to you, Brett.
Yeah.
Any RCT that also addresses implementation. There you go.
Yeah, look, I agree, but there are times where I might be controversial here, but why would we worry about implementation if something's not effective? And sometimes I think there's a need to either do both, but certainly there's a need to do both if it's effective, or an implementation-based piece of work is effective. But I don't necessarily agree that we should jump to implementation-based studies when we don't know whether something actually works properly or not. And so I think there's still a strong need for effectiveness-related studies, RCTs, in infection control, because actually some of this may be about de-implementation, which would still require implementation work, but or stop doing stuff that we're doing that we don't need to do, which probably leads me to the RCT that I'd like to do, which is gloves or gowns for certain types of contact precautions and whether they are needed. And whilst people are changing practice based on quasi-experimental and observational data, I think an RCT would be useful to help confirm those observational studies, or maybe we're causing harm by getting rid of gloves and gowns in certain situations. I like the other advantages if we don't need to use gloves and gowns, because clearly there's a huge environmental positive impact if we don't need to use them, and cost, as well as it'll help people actually perform hand hygiene when they're supposed to, because the 5 minutes of hand hygiene when someone's under contact precautions is exceptionally difficult to implement. So, there you go, Phil. There you go. You can have the implementation part to that RCT as
well. I'm interested in this one because I picked up on a couple of papers related to masks and gowns in my phys talk. And there was a nice piece of work from Mike Klumpus in the States where they taken away universal masking and screening for COVID, and there are hospital respiratory infections went up just in general, viral based in respiratory infections. And then there was a big increase in the amount of RSV around. So they went back to just surgical masking staff, and it came down again. Now, through COVID, there was all this discussion, where's the evidence for masks and where's the evidence N95 works? And there was loads of lab work that said these things work. But the argument was, where's all the clinical studies? Where's all the clinical studies? Now, I found a paper from Orsel and colleagues, and Juliet Severin and Andreas Voss were involved in this one, where they looked at a systematic review of role of gowns in preventing nosocomial transmission. And these were all clinical studies, and they found they couldn't find really good evidence that long sleeve gowns were effective. So what they then called for was laboratory studies to show that we don't get transmission. So the gown people want laboratory studies, and the mask people want clinical studies, even though they've got laboratory studies, and it's all PPE. So okay, funny, you're sort of picking and choosing. I don't want to wear a gown, therefore I need a piece of lab work to prove it, and should I wear a mask? I need a clinical study, and that's a difficult thing to do. So
they're all difficult things to do.
Yeah,
that's a good point, man. That's interesting. What about you, man? RCT?
I gave you the RCT. It was the pneumonia one. Wake up, it's late in the evening for you.
I'm having a senior's moment.
You are, and I'm the senior as well. So that's quite impressive. You young whippersnapper.
Now we've still got Phil's favourite moments. We might leave that just a tad longer. What about let's sort of before we get to perhaps predictions for 2026, maybe a quick reflection on infection control matters in 2025. Martin's probably going to have some interesting stats here, but I just thanks to all our listeners for listening in this year and the suggestions. And what I actually find fascinating is going to conferences or meetings and people coming up and thanking us for the podcast or telling us how enjoyable it is, or I actually haven't had anyone come up and say stop doing it yet. So that's good. I could always say stop listening then. So thanks to all our listeners for that. And our numbers are going to grow. I suspect there's a chance we'll hit 150,000 next year, which would be pretty incredible if we did. And we're certainly getting numbers for each episode after a certain period of time that would be bigger than any opening address at most infection control conferences globally. So thanks everybody. Martin, and have you got any interesting stats?
Well, we've had 15,000 listens this year. So it's quite interesting, really, because when we reflected back, we said, well, if we have a concurrent session for a conference, well, over 90% of our podcasts have had over 500 downloads. And actually 1 in 8 has had over 1,000 downloads from all around the world. So that's we're a niche. There's many more ID physicians, etc., and some of the other podcasts get much bigger numbers than us. But so we're a bit of a niche, I think, and I'm quite happy for that. Really, the number, we have a fairly steady population of people who listen to us. It's quite interesting looking at different countries though, because if you go to the States, we've got the two big groups who listen to us in state-wise are California and Florida. So that doesn't seem to be on sort of political bias, because you would say they were pretty much poles apart, but apart from opposite ends of the country. They're very much blue and red. So that just shows that the infection control desire to do well, I think, and be interested. It doesn't matter about your political persuasion, as you demonstrated at the EPIC conference. So, yeah.
All right, predictions for 2026. Phil, have you got any predictions for 2026?
Look, I was going to suggest preventable disease outbreaks in the US, but I won't go there. But I reckon I'm looking forward to some massive wholesale changes to our definitions of healthcare-associated infections to align with our use of EMRs and technology, Brett. I think we need
you think that'll happen in 2026?
Completely change the landscape. It'll happen in a few weeks' time. These things take time, but I think the seeds will start to get planted if they haven't already been.
Yeah, okay. Interesting. Well, I hope so too. Martin?
Yeah, I think using what we've got electronically to actually streamline the infection prevention surveillance process means there's much more of an opportunity for targeted surveillance. Yeah, Eileen Wolfensberger and co had that nice piece of work on automatically detecting HAP. Now, nobody ever does any work on HAP that's not ventilator associated, apart from doing a point prevalence study every sort of 5 years in the UK or every 30 years in Australia. And, finding out that that's the biggest group of healthcare associated infection and going, oh, that's interesting. And finding out the same thing 5 years ago isn't, I don't think, particularly helpful, but it's in the too difficult to do box at the moment. But if you can automate it, even if it is rough and ready, even if it only gives an indication, we shouldn't be left for people to actually spot something locally. And that's actually what I loved about that poster I chatted to Catherine about from Plymouth. They did root cause analysis on their C. diff cases, found that all these cases generally related to pneumonia on a stroke ward, put in a mouth intervention. Oh, look, pneumonia dropped. Oh, look, C. diff disappeared it was, I think, 12 months by the time she spoke at the poster. So, and that's the point about learning what's going on in your organization. And if you had an automated system, it would just give you so much freedom. I mean, I almost wish I was starting again just to take advantage of all this stuff, because it'd be fascinating. I was pieces of paper and actually going through lab reports manually, not even a computer when I started. T-card systems, well, that's not what I would call comprehensive.
Yeah. I'd probably agree with you both. I think for me, it's probably not a prediction, but an interest will be how much AI continues to evolve in the IPC space. I think that will include some of the things we talked about in terms of surveillance, but more broadly, I hope there's some big breakthroughs that will help efficiency and for IPCs who are generally overworked and time poor, and hopefully there'll be some technology that will make things a little bit easier so that people can get back to doing the things that we often talk about, not get back to it, but have the time to be able to do the things that we often talk about in this podcast around implementation, discussion, relationships building, communication, all those sort of
and actually sequencing, routine sequencing, if that could come in as well. That was a great paper from Alex Sunderman and colleagues back in Clinical Infectious Diseases earlier this year. They were spotting outbreaks on the second case, and something like 70% of the time they put an intervention in and it stopped the outbreak immediately. The one they struggled with was VRE, because that seemed to drift on and drift on and drift on and drift on. I was wondering about that one, and there was a paper from Johnny Maillard just a few weeks ago showing how VRE actually forms dry surface biofilms. So unless you really go to town on the environment, it's a gift for quite some time. So, I think once you know exactly what's going on and AI can start putting the pieces together, hang on, these people had that scope, that all these pieces of information are likely to be in electronic patient records within a few years. So just having something that combines it together, having systems that talk to each other, could be an absolute game changer.
I might, if you've got any thoughts about what you're looking forward to in 2026, I'm looking forward to some interesting conferences that are going to be happening across different parts of the world. I'm looking forward to hopefully getting a grant, fingers crossed for one. And I'm looking forward to finishing off 2 studies, one being a UTI, a CAUTI prevention study, which will finish in the middle of next year, called Hexadine versus Saline. And I'm looking forward to be able to share results from the HAPPEN trial as well during 2026, which obviously you two know about. So a few things there to look forward to for me in the IPC. Well, anything that from you two?
I'm looking forward to going to ESCMID Global, I think, in Munich, because there's often some interesting stuff going on there. And even if they don't always schedule the infection prevention stuff in a nice stream, so you can go and focus on that. But there's often some interesting stuff elsewhere. Some of the lectures you go and sit in, it's like sitting there in a fantastic scientific documentary. You learn a lot of very interesting things. So,
and perhaps into clean before that. Anything for you, Phil?
Look, I'm just looking forward to seeing you two again in the new year. Really, that's my highlight of the year.
Your prediction, Phil. I thought you were going to give us an Ashes prediction for the cricket.
No.
As this is going to go out just before Christmas, that series might be over by then. So.
The Ashes could well be over by then.
Yeah,
that's right.
No, we've got to have Phil's favourite point.
Yes. That's right. So let's go to Phil's
We've been
favourite.
saving
I didn't mean for it to be built up like that. But
Got a bit of work to do here, Phil. That's good.
but surely, Brett, it's the passing of legislation to turn our interim Australian Centre for Disease Control into a permanent Centre for Disease Control, which was passed only a couple of months ago. So for decades, many of us have been calling out for a CDC, and we've finally got it. It's now finally been legislated into a permanent state, and we know in politics permanency is really not permanent at all. But anyhow, what I'd like to share with you, though, that legislation was passed, ironically, the same week that ACDC were actually touring Australia. And in fact, further to that, the same week that there were 374 bagpipers who collected in Federal Square in Victoria and broke the record for playing Long Way to the Top for the Guinness Book of Records. So and if anybody would like to YouTube that,
that even made the news over here. So yeah,
it's a marvellous bit of footage. Yeah.
I just saw the photograph of the bagpipe, and then I thought, I recognise where that is. It's in Melbourne. What's going on?
That's very good.
Very good.
That's a good one, Phil. That deserved the hype.
Yeah.
All right. Well, gentlemen, it's always been a pleasure catching up with you, and thanks for another great year, and thanks to our listeners for listening in.
Yeah, thanks to the listeners. It's when you see people actually downloading it and listening, you think, okay, we can carry on with this. So it's motivating for us. So we appreciate it.
And a big thanks to Martin for all your work that you do with this, Martin.
I don't really do very much now. I'm afraid that I spent ages on YouTube learning how to edit audio and take out parrots and things like that. And now Adobe have got this nice voice enhancement thing, and I just upload it and it gives me back a clean version of that. So I don't even have to do that much anymore. So I learned loads of things, which I've since forgotten, of course, because I'm old, but I don't need to know them now anyway. So useful. Do
you remember we did that AI podcast?
Oh, yeah.
And it's pretty accurate. So one of the things I did for an AI talk at the SIPSI conference was I actually just went, I can't think it might have been Copilot, but I went in there and I just said, can you give me a summary of this podcast? And I just put in the web link for the podcast. And within 30 seconds, I'd had a summary of a 20-minute podcast saying, here are the take-home points in the podcast. So you don't even need, we can have AI develop a podcast, but now we can have AI analyze a podcast and give us the summary of this. So I wonder what AI will
People
say.
People even need to listen.
They might go, this Christmas special was a load of rubbish.
Yeah, they might read the podcast, which is like back to a blog almost. Yeah.
Next year's conference, you'll send your avatar along, Brett, to present. Is that...
very good. Yeah. Well, I wish you both a Merry Christmas, Happy New Year, and to our listeners, I hope you have a great New Year and stay safe during the season.
Season's greeting, guys. All the best to you both.
Ciao.
Enjoy the sun while I'm looking at the rain.
Ciao for now.
Bye, everyone.